You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Morning, little coffee chat by the warm glow of my computer screen, and we're talking about Sievers disease. You've probably heard about Sievers disease if you had a kid that's involved in youth sports, whether your child dealt with this issue or you know a friend. My first issue with Sievers disease, the fact that it's called a disease. So back in 1912, James Warren Sever coined this as a disease. It's an apophyseal injury. Disease makes it sound horrible. I get that it's maybe not completely terrible misnomer, but you know you get these crazy names for these apophyseal injuries like Osgood-Slaughter, Sinding-Larsen-Johansson syndrome. Pick your favorite. So it's going to affect kids that are in that 8 to 14 year age range. As I wrote about in The Age of Movement, this comes from the Canadian Spurts. This comes from actually the Windows of Accelerated Adaptation to Training by Ballier and Way of 2005. Just a great chart that takes you through the growth spurt cascade, and where this is going to usually show up is in kids that are in what's called peak height velocity, or PHV. That PHV is just when you're going through the biggest or largest amount of growth in your entire adolescent growth spurt. Well, then we see that kids are playing sport through this massive growth spurt. And as we know, bones kind of outpace soft tissue, in particular tendons and ligaments, as they take a longer time to accommodate to that growth. So we get an apophysis, which is a growth center. So it's basically in the heel, you have a big growth center, apophyseal or epiphysis in the back of the calcaneus that's not yet fused around this age. So as you grow and your tibia and your femur and everything is lengthening, and now your triceps sura, your gastrocnemius in particular, that attaches down to your Achilles is getting pretty wound up just from what is normal tension. It gets exacerbated by the amount of play. This really gets exacerbated in America, where we don't pay a lot of attention, if I'm being honest, to growth spurts as it pertains to sports physicals and what kids should be altering around play, which again I wrote about in my book, is talking about this Canadian Sports Center study that they basically looked at just easy stuff like a sit and reach test, their actual height and weight, and saw when kids were going through their biggest amount of growth spurt, and then reduced play and moved them away from skill acquisition exercise to get them into more mobility, strength and conditioning models that would allow them to not run into these issues. But then the interesting thing is, if we don't lose mobility around this massive growth spurt, around this peak height velocity phase, we see that you don't lose mobility later in life. So it's another important reason to work on it. So back to Sievers disease. As I said, it's almost always an issue of maltiming. That it's not normal to have Sievers disease during a growth spurt, but you add in a lot of play. You also add in things like restrictive footwear. So extremely common in soccer, where we're shoving a kid's foot into a small cleat, ask them to run around the soccer field or pitch for hours on end. And when your foot can't react to the ground and be as mobile as it should be, you're going to have even more stress around the ankle mortise joint, kind of up the chain. And here you go, you can have kind of more tugging on that apophysis from the triceps sura. I would also say that when we get into the rehab of this, that let's talk about treatment here in a second. So interesting article here that I'll put the link in the show notes, but this is just basically a Stats Pearl review this is updated January 11, 2024, so it's pretty updated. And it gives you the basics on this. There's nothing, crazy. One of the things that I did think that's a bit out of sorts is when it's just breaking down the prevalence and etiology of this. The last sentence in this little paragraph says, with no article to back it up. Mind you, because every other thing, so it says, however, the pain subsides with rest or when activity is stopped, with an article to cite that. The last sentence says, Sievers disease may also develop in less active adolescents who wear flat shoes, with no article to back that up. The old school thought process would be that you need shoes that support your foot, right? And maybe not too old school. If you go old school, you weren't wearing shoes. But the old school in terms of like coming up, around 70s, 80s, orthopedic medicine was we need supportive shoes for kids that are growing to support their arch, to allow that to develop naturally. That is not the case whatsoever. So I would argue that if a kid is wearing a flat shoe, AKA minimalist shoe, and they're actually active, which this is kind of the breakdown. They gave two different things in two different veins and then say that it can be a predisposing factor that they're wearing flat shoes and that they're less active. I would say less active and then getting into sports heavily, which is the case in our like 6th, 7th grade cross country runners. They go from 0 to 30 miles a week pretty quick. That can be an issue. Same thing with soccer. But I would disagree with the footwear thing completely. Now, getting into the treatment. So what is the typical treatment that we're going to see? Typical treatment is a kid gets taken into their pediatrician because the presentation of calcaneal apophysitis, Sievers disease, is what? It will get extremely painful. It usually with an apophyseal injury like this, you're going to have some sort of inflammatory cascade. So it's going to be maybe a little bit swollen. It's going to be red. It's going to be hot. Kids post-play or, hobbling around. So you get taken to the pediatrician. Pediatrician may diagnose them with Sievers, or they may, triage them to an orthopedist or somebody else. And we'll talk about that in another video. But once they get triaged, what's the typical thing? Well, they usually rest them. Sometimes they'll throw kids in boots, and it's almost like the orthopedic model nowadays is like a bad parking meter cop, and they're just throwing boots on every car out there, or in this case, every kid. I don't know why we still are hanging on to this mindset that immobilization with soft tissue injuries, this is a soft tissue injury unless we start seeing actual tractioning of the apophysis away from the bone, right? So if you have basically an epiphyseal avulsion, and that's called a Salter-Harris injury, and those are graded based on how far you're pulling the apophysis away from the bony end plate. So if we don't have that, immobilization is usually not the best option because we're literally talking about an injury, a disease, a syndrome, whatever we want to call it, that is being brought on by a kid that is going through a growth spurt that needs soft tissue to accommodate. And you know what the worst thing to get soft tissue to accommodate is to immobilize it. Because what do we know soft tissue is going to do? Well, surely not going to get more mobile. If we're talking about musculature, we know we start going under disuse atrophy pretty quick. So it's just not the best thing. Now, do we need to protect them from themselves and maybe limit sport? Absolutely. And this is one of the injuries, one of the issues in our clinic, which has always been a very active care model, not pulling people out of play unless we absolutely need to protect them from a legitimate injury. This is one of the issues that I do not think you get out of jail free. What I mean by that is I think you do need to rest kids. If you're in an inflammatory state of Sievers disease, it's just one of those few things that I think is very hard to calm down with the best conservative musculoskeletal modalities without having them take a break. That's just been my input. Maybe other people out there have better tools than I do. But what tools are we using in conjunction with a bit of rest if we see somebody is in a massive kind of flare-up or acute state? If you're not in that acute state, we don't see an inflammatory cascade, we may not rest you. It's all determined on an exam, which I always urge people. I love all the questions that I get on YouTube and other, veins, but when people ask for advice, it's very hard to give world-class advice without a world-class exam. So just take that 2 cents, find a good practitioner in your area. What are we doing to try to help this speed this up? Big things would be, we're not going to be stretching. You got to think, you're already tractioning on the apophysis, right? You're pulling on the apophysis from the triceps surae, the soleus, the gastroc. So you'd be like, well, how do you create a length tension relationship that's going to be amenable to not creating this apophyseal injury or irritation? Well, a lot of this comes down to time, which is why I think one of those rest things, because you're going through a growth spurt. What's one of the best ways to get tissue to accommodate is actually to apply load. And you can apply load in mid-range with safe, non-movement based exercise, aka an isometric. So we could have a kid literally get into the mid portion of like a deadlift, right? Your gastroc is working really hard if we have a decent amount of weight, and just doing isometrics there. We could do isometric squats, which require not a full stretch of the gastrocnemius or soleus. We can also work on motor control around that foot that may have been shoved into a cleat or some of their footwear that's restrictive or too small or whatever we want to say, not allowing them to react to the ground. And by motor control, we just mean the ability to use your foot in conjunction with other movements to improve stability, balance, the ability to move around without relying on passive tissues like ligaments and tendons. And, let's say in this case, the enthesis where a tendon wraps into the bone is not yet done under union. So now we start using that apophysis as a passive kind of braking mechanism. So we do sometimes elevate a kid's heel if we don't think they're in a super inflammatory state to offload the gastroc a little bit. That's going to be temporary, extremely temporary. We're talking a week, maybe 2 weeks max. We don't want kids to rely on these things and just think, oh, I can throw a heel cup in or throw a heel lift in and just go do my exact same stuff. No, that's not what we're doing. We know that pain will alter movement. And what we're trying to do is alleviate as much pain as we can so we can clean up motor control, stability, balance while we're working on these things, because we're not just treating an injury, we're treating a kid, and we're trying to make that kid eventually a healthy adult. And as we said, we don't want to create long-term compensations, lack of mobility that's going to follow them into adulthood. We will also do things like dry needling. So in this case, say they're in a massive inflammatory state, and this has been chronic. We'll see kids that, they go through cycles for months. We may want to re-inflame that and then apply load in a safe manner, as we said, and maybe an isometric or, some other fashion. But we want to calm down that area by actually re-inflaming it by kind of going in with, acupuncture needles, creating a mild inflammatory effect. So you recycle that whole acute inflammatory cascade of, cytokines and everything else that's going to kind of help us pull some of the inflammation out of that area, but also bring things to that area that would proliferate tenocytes that are going to help that tendon or that apophysis heal or become more robust. The one other thing I would say here is matching the phenotype. You can check out a video that I did on runner phenotyping, matching the phenotype to the treatments. What I mean by that is, and this is just a broad strokes approach, that if we get a kid that is relatively tight in general, and we're not just saying during this growth spurt, because every kid during growth spurt is going to lose a little bit of their toe touch or in range motions, but if they're relatively tight, we know that they respond better. That type of person phenotype tissue profile responds better to heavy slow load. This comes from the work of Keith Barr. In particular, I'll put a link up to that article as well. But heavy slow loads. So these may be those kids that we're doing eccentrics, that we're doing isometrics with heavy load. Versus, let's say we have our kid that's more on the further end of that Bacon criteria of hypermobile. We know that type of tissue profile, that collagen representation, is going to respond better to ballistic loading, plyometrics. Well, here's the crux. They're inflamed. The plyometrics and ballistics, aka running, jumping, is probably what's bugging them. So maybe we can't do that yet, but we think, hey, after the acute phase of rehabilitation for Sievers disease with that phenotype, we may want to kind of stiffen the chassis up of that child by applying plyometric, ballistic loading, jump rope, teaching them how to decelerate a little bit better. If they're going to, run into those passive tissues, aka tendons, that tendon's a little more robust and has a little bit better braking power, which then also gives them better feedback if you look at a proprioceptive model of tendons playing into the myofascial system. And then one other flyer here, just because we've run into it a couple times with patients, is basically congenital anomalies around the calcaneal apophysis, like a bipartite calcaneal apophysis, which basically just means that calcaneal apophysis is broken into two pieces, and you'll see more prevalence. We've had kids with bilateral Sievers disease with this bipartite calcaneal apophysis. It just means that you're more likely to get this or deal with this, and then it may be a little bit harder to alleviate symptoms. Last thing I'll say on Sievers is it's very interesting when you look at these research articles. They say what is common cause of heel pain in kids, from 8 to 14. It's 2 to 3 times more likely in boys than girls. Well, that doesn't mean that boys are more likely to get it than girls, in my opinion, because if you look at the data on sports participation, you're going to see that boys outweigh girls still by a landslide. So again, I just think you're seeing a population participation bias. So we need to make sure that we're not just saying, oh, your son has heel pain and he's a boy, well, he's got Sievers disease. It still warrants an examination, because every kid with heel pain does not have Sievers disease, which is so common of a diagnosis coming from all sorts of practitioners, that we need to just do our due diligence, make sure that it's actually going on. Sometimes not all the time. You got to make sure that you pull the trigger on imaging when necessary, and a simple x-ray can tell you if there is, been tractioning of the apophysis, Salter-Harris injury, away from the end of the calcaneus in this case. But again, imaging should be warranted on exam. We are a little more gung-ho or aggressive on imaging with kids and kids that are involved in athletics just for a protective purpose, right? If we're going to rest them for 2 weeks, do we necessarily need to image? It depends on what the exam's showing us and the severity of, the symptomatology, if they've had acute trauma, things like that. So I will put a link to the article, a StatsPro article, Keith Barr's work in there, a couple of links to videos. Let me know if you have any questions on Sievers disease or anything that I think I missed. And in terms of specific treatment, I gave you a lot of ideas, but as I said, it warrants an exam because we could call something Sievers disease all day long. Does not mean that's what it is. And even if it is, everybody is a unique individual, or N equals 1, and it could be for a variety of reasons. So again, let me know if you have questions, and we'll see y'all next time.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.